So good afternoon, everyone. I am so excited to welcome you all to this year's Stuart Rome Lecture. Whether you're joining us for the first time or are joining us in person or virtually, we're very pleased to have you with us. So I feel very privileged and honored to welcome our esteemed speaker, Professor Erin Fuse Brown, who distinguishes herself even among our former impressive Rome lecturers. But before I introduce Professor Fuse Brown, I wanted to take a moment to reflect on the generosity that has enabled us to welcome an impressive array of speakers year after year. As you may be aware, this is the 40th anniversary of the Law and Healthcare program we're celebrating this year. And we are very humbled and excited to have hit this milestone. But coincidentally, this is also the 40th year of the Stuart Rome Lecture. It started in 1984 when the Rome family endowed this annual lecture. And it was to honor the memory of Stuart Rome, who was a prominent health law attorney in Baltimore. He was a community activist and a patron of the arts. We are especially grateful to the longstanding support also of his Paula Rome, his wife, who recently passed away, and for their commitment to honoring the legacy of her husband through this continuation of the annual lecture. As I said, Paula Rome did pass away just in September after a life of community service also and commitment to the arts in Baltimore. And we'd like to really acknowledge and honor her legacy and the legacy of her late husband. And we do remain grateful for their continued generosity, which allows us to bring these amazing speakers every year. So today, Professor Fuse Brown joins a storied list of Rome lecturers, including Professor Lawrence Gostin from Georgetown University, Professor William Sage from University of Texas, Professor Robert Burt from Yale Law School, Nancy Ann DeParle, former director of the Centers for Medicare and Medicaid Services, Daniel Levinson, former Inspector General of the U.S. Department of Health and Human Services, Professor Abby Gluck from Yale Law School, Professor Hank Greeley from Stanford Law School, Dr. Aaron Kesselheim from Harvard Medical School, Professor Allison Hoffman from University of Pennsylvania School of Law, and our 2023 lecturer, Professor Leslie Wolf from Georgia State University College of Law and School of Public Health. Prior topics for the lecture have included topics like implementing justice in research, how economics fails health law, the cost of prescription drugs, AI in healthcare, neuroimaging, chronic pain in the law, and Medicare oversight, just to name a few. Lectures series have consistently offered insightful analysis and innovative policy solutions to the challenges facing our healthcare system. And I know this year's lecture on the financialization of healthcare and what can be done different in that regard. With that as background, I'm honored to introduce our 2024 Stuart Rome Lecturer, Professor Erin Fuse Brown. Professor Fuse Brown is a professor of health services policy and practice at the Brown University School of Public Health. She was previously the Catherine C. Henson Professor of Law and Director of the Center for Law, Health, and Society at Georgia State University. She received her JD from Georgetown University Law Center and an MPH from the Johns Hopkins University here in Baltimore. Professor Erin Fuse Brown's areas of research and expertise include health law and policy, healthcare finance, healthcare consolidation and prices, the Affordable Care Act, single payer and public option health reforms, ERISA preemption of state health laws, consumer financial protections of patients against surprise medical bills and medical debt. She also serves as a consultant to the National Academy for State Health Policy to provide legal and policy resources and draft model laws for its Center for Health System Costs. Professor Fuse Brown's work has influenced health policy at the state and federal levels. Her most recent work on the rise of consolidation in the healthcare marketplace and corporate ownership of medical practices has received significant media and industry attention. The topic is increasingly important to attorneys in all areas of health law and policy, and I know that Professor Fuse Brown's thoughtful and thought-provoking talk will give us much to think about and discuss during the Q&A after the lecture. So with that, I'll turn it over to
Thank you so much for that wonderful introduction and for inviting me to join you here for this 40th anniversary and 40th lecture, annual lecture of the Stuart Rome Lecture Series. I'm truly humbled and honored. That list of prior speakers are sort of the giants of the field. And so I'm just truly grateful that you invited me here to be here. So I'm very excited to be here to talk to you, even though this has been a tumultuous week, because I think in some ways it sort of just shows what's at stake, right? The topic that I'm going to talk about tonight, the financialization of healthcare, really at the end of the day is about the human at the end of the story, right? The patients, those of us in the communities that rely on our healthcare systems for our health and well-being, and for all of the, the businesses, the employers, the purchasers, everything sort of hinges on this big piece of our economy called healthcare, and it's increasingly becoming financialized. So I want to again acknowledge the generosity and the legacy of Stuart Rome, and really think about what that legacy has enabled in terms of thinking big thoughts that have hopefully shaped policy and research agendas well into the future and to this day. And his legacy really does invite us to confront the pressing challenges of our time. And so one of these pressing challenges, I think, is the financialization of healthcare. So financialization represents the paradigm shift that transforms healthcare from a fundamental social good into a profit-driven enterprise. So my remarks will aim to define what I mean by financialization, describe a few case studies of how financialization is manifesting in our healthcare system today, describe some of the inherent risks it poses to our society, and then start to think about a framework for what is that research agenda? What is the policy agenda that we can potentially all work on or invite collaboration on in order to confront financialization and some of the risks that it presents to our healthcare system and our society. So to provide a concrete instance of the ramifications of financialization in healthcare, I'm going to start with the tragic story of a woman named Sungita Rashid. So last year, in 2023, 39-year-old Sungita was expecting her first child. She and her husband chose St. Elizabeth Medical Center, which is a hospital in Boston, to deliver their baby. And Sungita was admitted to the hospital in labor on a Sunday afternoon, and by early Tuesday morning, she had given birth to her daughter. But as Sungita and her husband were celebrating the birth of their newborn, the hospital happened to be in dire financial straits. St. Elizabeth's was part of the Stuart healthcare system. And Stuart Healthcare, if you've heard about it in the news, was the product of a deal many years ago in 2010, where Cerberus Capital Management, a private equity firm, bought out a nonprofit Catholic health system in Massachusetts and converted it into a for-profit system. Driven by profit, the private equity investors proceeded to strip all the assets out of the Stuart hospitals, selling off the real estate and buildings and land, leasing it back to the hospitals and using it as leverage to acquire hospitals all over the country. Stuart, under the burden of the lease arrangements, the hospital systems, St. Elizabeth's included, started to have a greater and greater lease payment, rent payment, so they cut corners. They cut staff. They stopped paying their bills. They stopped paying vendors for important supplies. So a day after Sangeeta gave birth, her abdomen began filling with blood, and she was rushed into surgery. Doctors said they needed an embolism coil to block her bleeding, the device that was typically expected and stocked within their level 4 maternal care center. But because the hospital had stopped paying its bills to its vendor, the coils had all been repossessed by the supplier, meaning that St. Elizabeth's couldn't properly treat Sangeeta. In a last-ditch effort, her medical team transferred her to the nearby Boston Medical Center, but it was too late and Sangeeta died an hour into surgery. So Sangeeta's tragic story is emblematic of a broader crisis facing healthcare in the United States, and it's a crisis rooted in financialization. And the chilling reality is that more patients like Sangeeta are encountering life-threatening situations in an environment that's increasingly driven by profit motives rather than patient-centered care. So from this definition, what do I actually mean by financialization in healthcare? So financialization refers to that shift in the primary objective of the healthcare sector from the production of healthcare goods and services for the benefit of patients and communities to the production of wealth for financial investors. So traditionally, health systems and healthcare providers aimed to produce goods and services for the health of patients and communities. That is their mission. That is their professional ethos. What financialization does is it flips this paradigm on its head. The primary aim shifts from that patient care, community health ethos to producing wealth for financial investors. There are certain key elements that characterize financialization in healthcare. The first is a shift in governance. Financialization is accomplished by means of a shift in the governance and decision-making authority from healthcare providers, whose priority lies in patient care, typically, to financiers, whose priority and fiduciary obligation runs to the shareholders. The second is a shift from value creation to financial engineering. And what I mean by that is financialization emphasizes short-term returns, right? It's trying to make money for investors in a very short timeline and the best way to do that is through what we call financial engineering. So financial engineering tactics are things like gaming payment rules or using multiple arbitrage by simply making your firm size bigger so you can get a bigger valuation when you go to market, or consolidating the market and using your market power to drive up prices. Or it also means cutting costs and stripping out assets and making money in the transaction of the sale of the assets of a healthcare entity like Stuart Healthcare. And the reason why this is the focus and why financialization and its short-term emphasis on profits ends up tending toward financial engineering is it's much easier to make money rapidly through loopholes and financial arbitrage than it is to actually provide better value, more accessible, higher quality care that the market responds to, right? It's very difficult to actually make healthcare better. We know how much effort is spent trying to improve the quality and value of healthcare. So it's much easier simply to do this through cost cutting and financial engineering. The third characterization of financialization is this concept of delocalization and consolidation as a means to evading accountability. What I mean by that is financialization thrives on delocalization, which is the removal of the governance and responsibility from the local community or people who live and serve patients in the community, and taking it into a consolidated entity that is often either geographically removed or from a corporate structural organizational standpoint removed from those who are on the ground actually seeing the patients. So it centralizes and consolidates this power, both in terms of market power and aggregation, but it also delocalizes and takes the governance out of the community and up to a corporate parent. In a healthcare system with local governance, competition, and a functioning regulatory oversight, pursuing profits at the expense of patient would create severe reputational harms. It would create market pressures. It would create legal liability and other forms of accountability, but in a delocalized and consolidated entity, there is no accountability. There is no liability to the community. So the crux of financialization can be summarized as follows. It signifies this transfer, right, in terms of the transfer of governance, the transfer of assets, away from the community and the patients and even the providers themselves to the financiers. And when profit becomes the priority, conflicts of interest arise, where decisions are not made with patient welfare in mind, but with maximizing shareholder returns. And this marks a fundamental and monumental shift away from healthcare that's focused on patients. So profit in medicine is not a new phenomenon, right? So I'm not talking about something that has only started to occur in the last 10 years. The question of profit motive in medicine has been sort of a question that health policy, health law, medicine has grappled with really since its inception. The inflow of private capital is fueling a form of financialization that appears to be more intense and having greater and faster results, both sort of in terms of its scale. So it's in some ways, it's not so much as a new phenomenon, it's just a new scale. It's a new intensity that we need to confront this problem. And as the inflow of private capital fuels financialization of the healthcare system, it's actually important also to consider the positive case for harnessing private capital against calls to eliminate it altogether. You know, one of the responses to the Stuart healthcare crisis is to say we should just ban private equity from ever participating in the healthcare system. And there are two responses to that. One is it's too late on the one hand, and two, it is in some ways maybe too blunt an instrument. So I'll get into that in a minute. But the positive case for private capital is the same one that undergirds capitalism writ large. And that is, in a competitive market, the flow of private capital and opportunity for personal profits can generate valuable investments, produce innovation, efficiency, and quality potentially beyond what a public or nonprofit provision of those goods and services would accomplish on their own. However, that requires the market to be functional and competitive, right? And we know that the healthcare market is neither perfect nor competitive in most instances. There's also the practical reality, the one that probably is the one that shows up if you're talking to physicians, or if you're talking to healthcare entities out there, and that is there is simply a dramatic and uptick in the technological and administrative burden and complexity of practicing medicine and providing healthcare in today's environment. And so this administrative complexity and this burden creates a need for capital because it's expensive. It's expensive to invest in electronic health records and data analysis and all the metrics and to assume population health and to do everything that you need to do as a healthcare provider to manage value-based care or be paid on a capitated basis or to participate in an ACO, right? This is all very resource intensive and they need capital in order to do it. So there is merit to this account of healthcare providers' growing demand for more resources. For example, you talk to any primary care provider who is being asked to engage in value-based contracting, right? Or track a dizzying amount of metrics on quality just to be paid. And they will say they cannot do it, right? They cannot bear the administrative burden and still remain an independent practice. So one of the unintended consequences of the value-based care movement is the disappearance of the independent primary care provider. So private equity and insurer-based management companies offer to take the administrative burden off the shoulders of physicians. However, the physicians who are desperate for this help have to accept the deal, but it has become somewhat of a Faustian bargain, right? They need this help. But in exchange for shouldering or handing over this administrative burden, the financial investor also receives the keys to the practice, and in many cases for many physicians, their professional souls, right? They actually turn over what it means to practice medicine. So these distinctions underscore, well, I guess that this is the sort of positive, not the positive case, but the why. Why do we see so many practices, physician practices, so many hospitals, so many types of entities accepting money from financiers? Is because it is imperative in this day and age to do so. Not all forms of private capital drive financialization necessarily, right? For instance, venture capital typically invests in early stage companies without assuming majority control, as to be contrasted with private equity. And this longer term investment strategy may actually result in significantly different types of investments and types of strategies than, say, short-termism and private equity. And it might present fewer risks of abuse or serve a different function in the market. So this distinction underscores the importance of a precise definition of healthcare financialization, both for identifying the forms of financial investment that are the most vulnerable to abuse, but also not to overzealously choke off all forms of private capital investment that might be socially or economically beneficial. With all that said, policymakers, patients, communities, researchers are all sounding alarms over forms of healthcare private capital that does and can result in financialization. And there are two concrete manifestations I'm going to talk about tonight. The first, as you probably have guessed, is private equity investment. And the second is the vertical consolidation of the healthcare system by Medicare Advantage insurers. So I'm starting with private equity. Private equity has emerged as a key player within this landscape of financialization. Over the past decade, private equity investment in healthcare has surged, has reached nearly $1 trillion between 2011 and 2021. And in 2021 alone, private equity invested a staggering $82 billion across various healthcare sectors. So initially, private equity targeted hospitals like Steward and nursing facilities like HCR Manor Care. But in recent years, this investment has shifted toward physician practices, outpatient facilities, behavioral health services. Unpacking the private equity model is critical, actually, to understanding how it financializes healthcare. So private equity funds are investment pools that pool resources from a variety of institutional investors, such as pension funds, endowments, sovereign wealth funds, affluent individuals. And these funds are managed by the private equity firm, general partner, which then use this pool as equity. And it goes out to the market and it leverages that equity to obtain a loan, which is debt. And the combined equity and debt is used to acquire target companies, portfolio companies, they're called. When the private equity firm acquires a portfolio company, it is usually a mature company, one that's been around for a while, and it takes a controlling stake, majority interest in that portfolio company, to actively be able to oversee and manage the company with the objective of boosting profits, enhancing efficiency, reducing costs, and exiting the investment within 3 to 7 years with a 200 to 400% return. So contrary to its name, the financing model of private equity is not purely equity-based. It's only 30% equity from the investors, the limited partners and the general partner, and the rest comes in the form of debt, right? 70% of the amount that's invested is debt. And that's why the other name for private equity investment is a leveraged buyout. So the debt burden is not carried by the investor. The debt is loaded on the target company. It is loaded on Steward. It is loaded onto the physician practice. The physician practice is the one who has to repay the debt, not the private equity investor. So the private equity firm, how do they make money? They generate transaction fees, management fees, and along the way, and then their big return comes when they sell the company again, usually for a 200 to 400% increase in a short time period of 3 to 7 years. So the goal of private equity is to quickly maximize the profitability of the portfolio company and then sell them in a really short period of time. To accomplish this, they adopt various strategies, including increasing revenues, using financial engineering tactics, divesting assets, selling the land, selling the real estate, cutting costs through, usually in healthcare, how do you cut costs? You cut staff, right? You cut the most expensive thing in healthcare is the labor, and expand the size of the target through acquisitions. So the typical exit strategies include selling to another private equity firm, selling to an insurer or another publicly traded company, selling to a hospital sometimes, or taking it public, and also bankruptcy. That's another exit strategy. So in many respects, private equity represents just the latest iteration of this idea of for-profit corporate healthcare. It's been around for a long time, But there are three characteristics that set private equity somewhat apart from conventional corporate investment and characterize its involvement as financialization. So first, private equity is highly leveraged, as I mentioned. It creates this incredible debt burden on the target company and compels that target company to meet short-term financial targets to service that debt. So for instance, private equity firms often sell the real estate of the acquired hospital, as happened to Stuart, to a real estate investment trust. That transaction fee is taken as profit for the private equity fund. And then subsequently, the REIT, the real estate investment trust, leases back the hospital building back to the hospital that used to own, the hospital entity, that used to own the bricks and mortar at increasing lease rates over the time. And this cycle, of course, strips the hospital of the ability to survive financially. The second is a short-term perspective. So private equity takes a very short-term exit strategy. So unlike traditional investments that focus on sustainable growth, private equity has such a brief investment horizon that it involves a lot of risk-taking. Right, so there's a lot of risky strategies like financial engineering to boost revenue rather than pursuing strategies that create enduring value or investment. Financial engineering, as I mentioned before, involves exploitation of payment loopholes, right? Surprise medical bills, charging facility fees. Leveraging the ability to increase, as I'll talk about next, Medicare Advantage risk-adjusted payments. Right? These are all financial engineering tactics. They don't actually produce more or better value care for any patient. And then they do a lot of cost cutting. And again, this is typically done through labor cuts, staffing cuts, staffing replacements, and also reductions in sort of suppliers and vendors. All of this, the two together, the short-termism and the highly leveraged nature of private equity, creates an asymmetry that gives rise to moral hazard, meaning the investor can basically profit without bearing any of the risk of loss if their venture fails. After all, the debt is tied to the acquired company, and the investor's potential losses are confined to their limited capital investment. And they are not long-term institutionalists, so they don't care about their reputational risk. Right? Cerberus Healthcare, that invested in the Stuart Healthcare hospitals, had long exited before Sungita Rashid died. And so even though Stuart was in the news and its CEO, Ralph De La Torre, was dragged before, well, I guess he evaded the hearings, even though there was a lot of public outcry and shaming of the Stuart Healthcare brand and the management of Stuart Healthcare, the Cerberus capital investment firm had exited the investment years before and basically will escape, I think, without any liability whatsoever. So the Sungita Rashid story really does illustrate the human toll of private equity's financialization. So as we said, it illustrates all of the strategies and all the risks that we just talked about. So Medicare Advantage is going to be the second example or case study of financialization. The second example of financialization comes from this other source of private capital that is now flowing through the healthcare system. And this is not just the presence of privatized Medicare Advantage plans in the Medicare system, but particularly the vertical consolidation pursued by Medicare Advantage insurance companies, exemplified by the corporate giant United Healthcare. So Medicare Advantage serves as the private insurance counterpart to the traditional Medicare program and now covers more than half of all Medicare beneficiaries. And under this system, the government provides Medicare Advantage plans with a capitated payment amount. That is a fixed payment per member per month. And these payments, Medicare Advantage plans know that these payments can be increased if based on the diagnosed health conditions of the beneficiaries they cover in a method known as risk adjustment. However, many Medicare Advantage plans don't just sort of code what they see. They engage in practices to maximize revenue, maximize profit. So what do? They exaggerate, they upcode, they increase the number of recorded diagnoses to inflate their risk-adjusted payments, resulting in an estimated $88 billion in annual overpayments compared to what these beneficiaries would cost if they enrolled in traditional Medicare. So private Medicare Advantage insurance companies have been actively pursuing vertical consolidation as a strategy of financialization. So vertical consolidation refers to the process where different entities in the healthcare supply chain combine into one single corporate umbrella. So what this means for United is Optum is part of United Healthcare, and Optum is the largest employer, I put that in air quotes, largest employer of physicians in this country. 1 in 10 physicians is an Optum physician. But Optum doesn't just, of course, have physicians. It also has United also has one of the largest pharmacy benefit managers. It often operates specialty pharmacies. It also bought Change Healthcare, that giant healthcare data processing firm that got struck by a massive cyber attack earlier this year, right? So Medicare Advantage is doing all of this, but I'm going to focus on the Medicare Advantage insurers' purchase of the primary care physician. The primary care physicians are being targeted by Medicare Advantage plans because they can engage in more risk code inflation when they own the practice. And the way they do that is they own the EHR. They program the EHR so you can't even get out of your screen until you click through all the prompts saying, it looks to us like this patient has this diagnosis, right? Do you want to exit now? I mean, we all know how frustrating that is. And clinicians are given financial targets and incentives. Have you hit your coding targets this month? Aren't there, like, let's have AI suggest some diagnoses that you might have missed. Or we're going to send a bunch of people into the clinicians, nurses often, into the homes of beneficiaries to do health risk assessments and annual visits and use that to diagnose and chart a bunch of diagnoses into the chart and provide no follow-up care, right? Appears to me that you have major depression, no follow-up care. Appears to me you have HIV, oddly, no HIV medication prescribed, right? Like, so it is, these efforts are almost transparently designed just to increase reimbursement and not to provide more care. At the same time of this sort of aggressive upcoding of diagnoses, there's a reduction in spending on care itself. And this is accomplished through prior authorization denials, often driven by AI algorithms. Also, the idea that there's just a lot of utilization management, which can be consistent with good managed care, but these practices are done, again, not with an eye to providing sort of appropriate care, but to sort of maximizing the delta between how sick a patient looks and how much you actually have to spend on treating them. And that's profit. So reports from the HHS Office of Inspector General out just this past month indicate that these plans, these Medicare Advantage plans, employ strategies like these in-home health risk assessments, like chart reviews, which are data scraping exercises to increase and generate diagnosis code to enhance their risk-adjusted payments without providing necessary follow-up care. And no Medicare Advantage plan does that more than United Healthcare. Additionally, these insurance companies are simultaneously, as I mentioned, cutting costs, right? They're cutting costs, they're cutting amounts spent, and they're increasing that profit. So when physicians affiliate with a Medicare Advantage plan, meaning they either get acquired by Optum or sign a management services contract with insurance company, it's not just United, physicians may, again, be promised, we will take the administrative burden of managing capitated payment or subcapitated payment or population health risk or all this charting and data off your backs, right? You can just practice medicine. But what they find is that they experience burnout, they experience demoralization, and they experience this sort of crisis of conscience because they go from being professionals trained with a skill set to bring to bear, trained in professional and ethical obligations and fiduciary obligations to the patient. And that is now coming into direct conflict with the command from the managers saying, you got to hit your targets. You got to make more money, right? You don't want to be on the blacklist this month. And so this demoralizes the workforce. And so if it's not the only reason, but one of the reasons we have a primary care crisis in this country is the demoralization of the primary care workforce by the process of financialization. So vertical consolidation of Medicare Advantage plans illustrates financialization again, within the healthcare system, right? These companies and these arrangements are not prioritizing the delivery of superior or higher value care for Medicare beneficiaries. Instead, these insurer-driven consolidation attempts rely on a financial engineering tactic, risk code inflation, to transform taxpayer-funded Medicare dollars into profits for shareholders and investors in the insurance sector. All right, so what are these, what could possibly, I already illustrated all the things that could go wrong. Let me just summarize. So there are sort of three buckets of harms that I've described tonight. One are the cost increases, right? There's all of this drives higher spending. It drives consolidation. It drives price increases. And it doesn't do so in any way, and the research shows this. Private equity buys hospitals or physician practices, prices spike double digits, right? Private equity acquires physician practices, and we see spending go up through higher utilization. Medicare Advantage plan acquires physician practice, risk coding spikes overnight. So that's what the evidence is beginning to show. The second harm is harm to patient care. This one, of course, is a huge concern. This increasing financial pressure leads to concern about the quality of care being delivered because of the incentives to cut staff, to cut costs, cut corners. And studies have started to show a troubling increase particularly in the institutional settings like hospitals and nursing homes. Private equity acquisition is associated with increased adverse events, infections, hospital-acquired infections, avoidable complications, and a staggering 11% increase in mortality at private equity acquired nursing homes, likely driven by staffing and other cost-cutting measures. That evidence, to be sure, is not present necessarily yet for physicians. We don't have similar quality drop-offs in the physician practice context as we do in the institutional context. But we do see that there is a third harm, and that is the burnout, exit, and demoralization of the clinical workforce. All of this, of course, creates more turnover, substitution of physicians, people retiring early, exiting the profession, stop seeing patients or stop participating in provider networks and going into concierge, right? Because they just can't deal with the loss of their professional identity through the process of financialization. So in sum, financialization presents a significant threat to both the healthcare system, but also to our society. This is a fundamental transformation that is sort of siphoning off huge amounts of, again, the taxpayer-funded healthcare system and putting it in the pockets, not of even the healthcare providers, right? It's not going into the pockets of the physicians or of the hospitals even that serve the communities. It's going into the pockets of profits, shareholders, and the executives of these corporations. However, the profit-driven entities like Welsh Carson or Cerberus, United Health, Humana, CVS Aetna, and real estate investment trusts, they're gaining more influence, right? They're gaining more, as they get more profitable, they get more politically powerful. And so any effort to cut costs is an effort to cut their revenue, right? And so they become a formidable political adversary. All right, so when we think about what can we do about this, I'm gonna remain with my remaining time. I'm just gonna briefly summarize. I've written elsewhere a litany, a laundry list, menu, I've called it, of policies that might respond to specific concerns of financialization by private equity or by Medicare Advantage-driven vertical consolidation. For example, strengthening antitrust law to get at the forms of vertical or serial consolidation pursued by these types of entities. Enforce existing fraud and abuse laws to get at the upcoding, get at the patient self-referrals, and then the inappropriate billing pursued by private equity-backed physician practices and Medicare Advantage plans. Third, Congress could close Medicare payment loopholes, such as Part B payment methodologies for physician-administered drugs that are being financialized in ophthalmology practices, or Medicare Advantage risk code inflation and meaningless quality bonuses, transfer pricing by these entities to gain medical loss ratio requirements. It's like totally nitty gritty, in the weeds, wonky stuff, but these financial entities find these payment loopholes and move aggressively into them in order to make profit. So close those loopholes. Number four, policymakers could strengthen protections for clinical professional autonomy. by strengthening the old corporate practice of medicine doctrine that's on the books in many, many states. Something that we thought like, we don't need this anymore. Why would we need? Well, apparently we had no idea the degree to which corporate practice of medicine could take the shape of things like private equity or insurer-backed management services organizations. So states are looking at that in particular. And then finally, provide transparency of ownership or control entities. All of these financial control relationships need to be transparent to researchers, to policymakers, to regulators and enforcers, because we cannot study what we cannot see. So I stand by all of these, and I've been working with policymakers, federally, state, to kind of implement as many of them as we can. And that work is ongoing. But what I'm here to do tonight is to really create a framework for recognizing financialization, for understanding what it is, so that we all can collectively confront, if we're interested in it, confront financialization. And I sort of is like, this is where I'm like, I now am like moving off of the nitty gritty policy recommendations to sort of like these blue sky ideas. Where do I think others can be able to contribute their thoughts, their creativity, and their efforts? So having a specific definition of financialization helps in this matter. The definition that pinpoints the modus operandi, this profit over patient, and specifies the means by which it occurs. Governance is shifted from communities to corporations. And then looks at some of the characteristics, right? Financial engineering, delocalization, consolidation that produce these harmful effects. Once you sort of have an idea of like, now I know it when I see it, right? I have some ways to measure or at least recognize financialization when it's happening and know how it's happening. That might set up a broader policy and research agenda. Again, one that I invite all of you here and researchers everywhere, including law students. If there are any law students watching this, like, I need a research paper, I need a law review note idea. I like, here it is. I'm giving you, I'm in that meeting and I'm saying, here's the things that you can look into. I do not have all the answers. I'm just presenting questions at this point. So the nascent ideas I have fall into two broad categories. One are to think about how we could reform healthcare ownership, structure, governance, and liability. So that's one bucket. Think more carefully about what we can do about governance and ownership structure and liability. Second bucket are what can we do to reform healthcare labor policy, capital policy, and payment policy. All right, so on the first one, ownership structure, like one of the keys to confronting this issue appears to lie in this critical question of ownership structure. We need to reconsider. It seems kind of quaint and old-fashioned, again, kind of like the corporate practice of medicine. We need to reconsider the value of the question of who should own healthcare institutions, and should we allow financial institutions to own and control all forms of healthcare delivery? I don't have the answer to this question, but my current work on strengthening the corporate practice of medicine sort of is a version of this, right? It sort of asks, okay, if the corporate practice of medicine doctrine is supposed to prevent lay, unlicensed corporate entities from owning and controlling physician practices, well, what about hospitals? What about hospices or skilled nursing facilities or home health agencies that are serving vulnerable populations that are primarily Medicaid reimbursed? Should they be for profit? You know, that's an open question. So corporate practice of medicine only takes us so far. So what is the analog for these other types of entities? And if they're, you know, should they be nonprofit? Even if they're not nonprofit, how do we protect publicly funded assets like a nursing home facility from profit-driven maneuvers like sale leasebacks that strip and staffing cuts that strip away valuable resources? And then more broadly, how can we think about the role of public ownership in healthcare institutions that was more common in the past and still exists in many forms, both in this country and in others? The second question on governance, it's a related concept. Ownership issues are very closely tied to governance. So I think that we should examine or re-examine the roles governing bodies play within their healthcare organizations and their fiduciary responsibilities. How can we reorient the goals of these organizations to prioritize community health over shareholder profits? Well, conveniently, nonprofit organizations are legally mandated and organized to operate for charitable purposes. So that would be an excellent starting point. They are meant to serve their communities and require that boards be made up of local representatives to retain their federal tax-exempt status under the community benefit standard. Recently, some states have begun scrutinizing nonprofit hospitals, questioning whether they have prioritized patient profit in a way that should cost them their state and local property tax exemption. Right? We could do more. We could lean harder on the community benefit requirement, enforce it more vigorously in order to kind of bring back sort of this local ethos of community benefit. I know it's like in vogue to criticize community benefit and to say it's not doing anything. Doesn't mean it could never do anything. And maybe we really need to strengthen it rather than throw it away. And then finally, there's this issue of liability. While completely banning private capital from healthcare may not be practical or desirable, we should potentially rethink the limitations on liability that exist for corporate health entities and their investors. So to mitigate some of the risks associated with financialization, it might be necessary to figure out ways to pierce the corporate veil or to allow corporate investors to be held liable, even if they construct these very complex corporate structures to evade accountability and liability. And then finally, on the healthcare payment, labor, and capital policy, payment policy, I talked a bit about closing payment loopholes, but I think we also have to think about other ways we might change the way we invest, use payment policy, for example, to shore up primary care, right? To really rethink, is managed care, value-based payment and capitation the best way to pay for primary care? Ask any primary care provider and they're saying, we're not getting a piece of that, right? It's not helping us. It's making us lose our souls. And so maybe we have to rethink sort of the whole capitation value-based ethos that we've sort of accepted hook, line, and sinker, and also think about ways to reform physician payment policy to truly invest in primary care. And that would, of course, would require probably some change to the physician fee schedule under Medicare. And that relates to labor policy. How do we train more primary care physicians, nurse practitioners, and others who can fill some of these gaps to make up for the shortage that we're now shedding in many areas, things like, fundamental services like primary care, but also behavioral care and others. And think about alternative sources of capital. Capital financing is at the core of the challenges posed by financialization. As I mentioned, many healthcare providers and physicians feel they have no choice but to sell because to a private equity firm, to a health insurance company, to a health system, because they cannot survive under the current environment without that influx of capital. So we could provide more guardrails on private capital, but we could also explore alternative sources, right? Where are the traditional bank loans? Why aren't those being used? What about municipal and tax-exempt bonds? What about public provisioning of essential services, public grants, right? We could think about other ways, again, that may not be an exhaustive list, to provide alternative sources of capital. So as I mentioned, these are just nascent blue sky ideas, present more questions than answers. I have not thought all of these through. I truly invite anyone to take any one of those and turn it into their law review note. You will not be preempted by me, just because I said it tonight. I invite you to use your creativity and to tackle the problem and to use and come up with creative solutions that I haven't even thought of here. So as I conclude, I just want to say the fundamental underlying question of all this work for me is this question of, is healthcare just merely another commercial economic commodity? Or does it hold a special position as a social good that is critical for our societal well-being and flourishing? I think it's the latter. And so I think we have to confront the realities of financialization and its adverse implications for our society. And so the practice of specifying the phenomenon and like in the nitty-gritty details of unpacking what it looks like and how it works and what are the levers and what are the drivers, all of this is really so that we can try to promote the welfare of actual living people and communities rather than the profits for corporate persons and investors. So thank you so much for your engagement, and I look forward to a rich dialogue with all of you.
very much
Thank you.
for that presentation. That was so informative and fascinating. So we do have some time for questions, comments, thoughts. I know you have a background that, yes, Joel?
Nice to see you, Erin. Is there any value in having measurements, assuming that the world is corporatized, assume that financialization is here to stay? Is there any way to harness the measurements of a company's performance so that, yes, it's a for-profit motive, but when you don't meet the patient's expectation, when you don't achieve quality goals, that there is a real connection in the mind of the investor, the owners, that yes, their stock price will take a hit. And you see a little bit of this, you know, with Medicare Advantage, where there is this quality system,
Right.
star rating and so forth, and we won't go into how
You lose
meaningful
how
that
a star
ultimately
and- right.
really is. But if it did work well,
Yeah.
okay, sure. I mean, every time a star rating goes down, those plans go crazy and they sue and everything else. But if you really were able to connect stock price at the top to patient quality, patient service, whether there's much of a direct correlation, wouldn't that be a way to harness financialization to what used to be the nonprofit community good context that previously existed?
Yeah, I think that there's certainly ways. I hesitate to like put more quality measures on anyone in the healthcare system, but I agree with you that for the healthcare, the MA plan, the Medicare Advantage plans, the star ratings are tied to how much they get bonuses, right? The quality bonus payments are intrinsically tied to their star ratings. So it's kind of like you teach the test, you perform to the star ratings. And the problem, I think, as you know, is that the star ratings are meaningless. They're bogus, and they don't actually measure things like how much prior authorization denial is done, how much inappropriate AI usage, how much inappropriate health risk assessments are you doing. But were they to do that, then you're right. I think you could potentially tie payment to quality in a way that, if you measured quality in a way that actually mattered to beneficiaries and to the public, as opposed to the current star ratings, which are not calibrated in that way.
Professor Fuse Brown, my question pertains to the use of AI algorithms by big health insurance companies. My name is Michael Vinduan. I graduated in law school 2016. I'm the president of the American College of Legal Medicine. We work with AMA to advocate for physician-led care to the US Congress. We've learned that a lot of these big health insurance companies use AI algorithm to determine how many percent they will approve or deny the pre-approval. Let's say I'm a doctor, I want this patient to undergo surgery, I submit it to United or Kaiser, and AI algorithm is set to approve, let's say 4% only per year or per month. And there's no guarantee that it was actually seen by an actual physician. And the physician finds out it's disapproved. He or she would assume that a doctor look at it, but in fact, it's not, it's AI. And they can do this, they can dial up or down. So my question is the use of AI in this situation similar to, something like I have kids and I tell them not to use their cell phone, and it's not going to happen. So is this going to be the same thing, that we're not going to prevent the use of AI in the corporate practice of medicine or in the financialization of medicine?
Yeah, I think, again, it's a very good question. And I think it relates to this concept of the sort of demoralization, the workload, because for every, as I think we were speaking about this earlier, for every prior authorization denial that is generated by a Medicare Advantage plan, whether through AI or not, it generates more work for the clinician who has to either appeal it or provide further documentation just to provide care for their patient. Their patient is going to go without care if they don't somehow resolve this denial. And so it creates this huge amount of burden on the physician practices and on the physicians and the clinicians. Can we just outlaw the use of AI? I mean, like, I don't know if anyone has tried to outlaw AI in any other respects. For example, use, law school assignments or anything like that. It's very hard to do, right? And so I think you're right that it can't be sort of this whack-a-mole simplistic, like, private equity's out, AI is out, like we just have to ban it, right? Because it's like, how are you gonna enforce it? You're not changing, if you don't change the financial incentives or the ability to profit from financial engineering tech, they'll just find a different one, right? And so it's just, I think it's closing payment loopholes, it's cracking down, and that just sounds like it's a form of financial engineering, right? Like, well, why don't we just use AI to generate X profit instead of actually doing something that is valuable to patient care? Right? David?
Just as a follow-up, since we're all sort of brainstorming in the bubble a little bit, I wonder, it seems like we're just maybe sort of just constantly spinning and spinning because we don't like private equity, don't like, Medicare Advantage, as if to say in the good old days, there was a good old days and it was fee for service, but we didn't like that either. So with fee for service, we didn't trust the docs. It was alleged, and maybe evidence was there that they were upcoding and offering services. So the system has always been trying to adjust to figure out a way to get it right, to get the right care at the right time, no inflation over here. And now we're over here, and it's like, oh, the private equity, the funders there now squeezing and not squeezing too hard. And so I don't know, maybe one question is there a point in time when we or anybody else had it right? And do you see us, if not, do you see us finding our way, I guess, to the next iteration where we might be a little closer?
Right. Yes, I think there's no halcyon prior time when everything was perfect. And I think we're just trading different problems for different problems, right? Like nobody thinks cost-based reimbursement was good. And then we're like, okay, we have this like IPPS, we have like, episodic reimbursement in Medicare, it's gonna solve it all. And of course it didn't, it created its own distortions because of the volume of money, right? It's so much money that there are going to be, I think that's the overarching framework, is that there's so much money that no matter how you channel it through the healthcare system, if you allow ways for private investors to siphon off that money into profit, they will find that way. And they will find it whether it's fee for service, they will find it whether it is value-based care, and they will find it whether it's capitation. And I think that, I guess what I don't know is I don't know how to do it better. There's a part of me that's like, I'm really kind of ready to throw in the towel on value-based care. I know that's like really, really, which isn't to say like fee for service is not perfect. So like, what is the version of payment? What is the version that would make, particularly for primary care? I think particularly for primary care, what would it look like to actually provide the type of resource that we would need to actually resource primary care properly in this country? I don't have that answer, but I love the question. So again, let's throw that into the hat of like things people need to be working on.
Grayson?
Hi, thank you so much for speaking. I'm a 1L and my torts professor's in the room, so I have a question about duty.
Yes.
You were talking about the tension between the fiduciary duty with these private equity firms and their shareholders and the fiduciary duty between the doctors and their patients. Do you think that this tension between those two duties requires us to reconceptualize the idea of fiduciary duty? Or do you think it's perhaps like a good foundation for an argument that corporations should not be in charge of healthcare because they're taking on these inconsistent obligations?
Yeah, I think the latter. I think that's a good way to think about it potentially. And I think it's sort of like, reinvigorating, going deep on fiduciary duty, which again feels kind of old school. And the narrative, like, 20 years ago, it's like, oh, those greedy doctors, they don't, fiduciary duty to their patient. They don't take it that seriously. They're just in it to make money. Doctors are just profiteers, just like the rest of them. And then we see what happens when private equity takes over doctors or Medicare Advantage, and you realize wow, fiduciary obligations to your patients was doing a lot of work. And so that's the part where I sort of caution throwing out old school, like the community benefit standard or the fiduciary obligation of the physician. Because when we lose it, we realize how much it was still doing. And so it's also in vogue to say, well, these nonprofit health systems are not acting charitably. So like they should just we should just get rid of the nonprofit tax exempt form because none of them, they're all profiteering. It's like, well, no, if you do that, then you lose the community benefit standard. Why not double down on it? Why not make it have teeth? Why not take away their state profit? So, sorry, long digression to your question. Great paper topic. I hope you write that.
Really, like, the thing that I hear that's implicit in what you're saying is that CMS has completely abdicated any responsibility to enforce laws and regulations already on the books. And in addition to that, the quality-based payments are not really effective because the private equity investors are not looking at it in a long-term way, short-term way. So that's not even working either. What do you think about the model of like a federally qualified health center or like restructuring payments in that way?
Yes, I think that there is a role. I mean, I do think I wouldn't necessarily say CMS has totally abdicated. I think CMS is totally under-resourced. It cannot possibly deal with the level of overpayment that, I mean, it's trying, it is trying, it can do more. It could use more resources to do it. I think that your last point is really well taken. I think, again, we should not forget the models of public provisioning that we have throughout our healthcare system, and federally qualified health centers are like a big example of that, of direct like public investment in healthcare resources. In some ways, we shouldn't have the limits on the number of FQHCs that we have today. There should be more of them. There should be more federal dollars. I mean, I know I'm like speaking in a theoretical way at this very moment, but yes, I think absolutely there should be, I think this idea not to replace the private health system, but to say where are things still working and where can we shore up and like where can we have these alternative sources of capital that will, the FQHCs are powerhouses and they do a lot. And so why shouldn't we just think about building on that a bit more? Again, it's not the whole solution, but it's like a big part of this. It's a significant part of it.
Thanks for really provocative. I have so many questions and comments, but that's not fair. So I'll try to limit myself. First of all, with all the upset of primary care physicians, and as you acknowledged, that issue of primary care physicians goes way back, and it has a lot to do with the culture of medical education and how much they get paid. But one radical idea, like other countries, is we could give them a salary. They won't have any moral distress associated with having to code things in certain ways. It's never going to work. But I think you have to think about, would these issues be solved if everybody just made a certain amount of money? And what would happen to the profession? Okay, that was one.
Okay.
If I squeeze in, I haven't heard anything about medical malpractice and you talked about liability, but I don't think in corporate liability, but in the context of medical malpractice, when you started with that example of that woman, I mean, who's liable? Because obviously there was negligence. And the worry, of course, is if we get more and more and more of this kind of model, the standard of care is going to just go down because we're not doing much for anybody. And I don't think you're implying that, but if you could talk a little bit about those two ideas, and the rest I'll deal with at dinner.
Yes, long conversation at dinner. On the primary care side, I think that there's, there are a lot of creative ideas about alternative payment models, not in the MIPS sense, but in the like true sense of like, how do we pay for primary care in a way to make it sustainable? But I also think we have to think about who is paying the primary care provider. Because if the person who is paying your salary is still profit seeking and owes profit to shareholders, then it doesn't matter how big it is, like, they're gonna put incentives in place that it's gonna say, the more you make for us, the more you make. Even if we set it at some, true living wage for primary care. And make it competitive with other specialties. But I agree with you that there should be deep conversations about how to pay for it. It's not enough to just sort of like, go back to the old fee-for-service way that totally penalized primary care. Your second question, remind me your second.
Medical
malpractice. Yes. And I think that that's one of the big issues, and it's not actually something I know a ton about. So that's, again, I invite all the people who are expert at malpractice or torts to really think about this. Like, how do you attach liability? And again, the goal is not to, you're right, malpractice occurred. Was it the fault of the sort of the clinical staff in the OR who reached for the supply and it wasn't there? Was it the fault of this supply department that didn't ensure that the supplies that they needed were there? Or was it the fault of the corporate who stopped paying their bills because they were bankrupt? And so the supply got repossessed. And how to kind of do that in a way that actually tracks to like enterprise liability all the way to the top. And Rob Field, our colleagues Rob Field and Mary Furrow and colleagues, wrote an excellent paper on private equity, barbarians of the gate, they call it, but it really thinks about sort of like, how do we press on fiduciary standards? How do we press on, negligence liability? Because, this is just one example, but HCR Care, it was a private equity owned nursing home, same thing, dramatic staffing cuts, dense. And it's like, and the private equity company got away scot-free. Like, there was an attempt, the family sued the private equity company and there's a dismissal of them from the lawsuit, just saying.
So that's an area where there could be some
Yes.
change.
Yes.
Well, I think that if we don't have any more questions, I would like you to join me again in thanking. That'd be really wonderful. So, and now I hope you can join us outside. We have a reception for a little bit of food and drink. And I hope you'll also join us for some future health law events. Next week, we are having the second in our Rothenberg Health Law Lecture Series, Speaker Series, and that's going to be co-sponsored with the Gibson Banks Center, and that will be on Thursday again at 4:30, and Professor Kiera Bridges from UC Berkeley School of Law will speak to us, it'll be virtual, on the topic of expecting inequity, race, class, and reproductive justice. And we'll also be hosting the law school's final anchor event of the fall on November 18th on health law at the Supreme Court. And then closing the semester, we'll be co-hosting an in-person and online event on December 4th, co-sponsored by UMB's Center for Global Engagement on white health and international law, that will feature Maryland Carey Law Professor Matiange Sirleaf and Professor Saye Mbimbola from the University of Sydney. So thank you so much for joining us today and for all your support for the last 40 years.